So basically, I'm going to talk on upper limb, which predominantly is shoulder, okay? And my main area is shoulder surgery, but I do a lot of hand surgery. I do some knees as well. And but probably the bulk of my work is shoulders, and part of the reason is because a lot of people don't like shoulders. They find it pretty hard. And really, I think in any orthopaedics, nothing's shaking. Yeah, one table there, yeah. Okay. The thing is with any areas is to keep it simple. So I first of all start off by saying the basics of any medicine area. You probably don't know all this, so it's probably all basic reminders to you. But when I went through medical school, we were taught basic sciences, and then we were taught examination techniques. Okay, you practice all the time going around doing percussion techniques and listening to hearts and everything, and examining how they examine the shoulder or the hand, with the idea that we'd go along and see a patient and examine them. You know, and really, what's the most important thing about finding a diagnosis? And I'll give you a clue here. If I'm going to tell you what's the most important thing about finding something in this room, and I'm going to teach you techniques to find something in the room, such as looking underneath something. You can actually move things around. You can walk around the back of it. If I then ask you to find, go and find something in the room, what's your first question going to be? What are you going to find? So when you go to take a history examination, you need to know what you're looking for before you actually can take a history examination. So you need to know the diagnoses that can occur. You want to keep those as the most common ones, because common things occur commonly. And I know that you're taught the mnemonic of the surgical sieve. I think there's one, vitamin D. Vascular, inflammatory, traumatic. I always found that one. I don't know what you guys are like, but I always found that one hard because you're on your feet when what are the cause of these things? You go vascular, inflammatory. It's fine for cardiac because obviously most things are vascular there. And rheumatoid, you've got inflammatory right at the start, but most things aren't really that easy. They don't roll off the tongue. So I found it easy to divide things up into two different areas in the way they present, a patient presents. So you need to know the diagnosis of a condition before you can actually form a diagnosis. So you need to know the actual different conditions that are going to occur before you can form a diagnosis. You need to know a way to remember the diagnoses, okay? And I found it by the way a patient might present. So how can a patient present to you? If you're seeing a patient around the place, how will they present?
In pain.
Yeah, they'll present in pain, so they might present acutely in pain. Or that's a type of symptom they have, and that's actually what you've been taught right from the start, symptomatic diagnoses. But really, when you actually see a patient, where will you see a patient in this hospital? You can see them on the ward or in ED. You can see them in a traumatic scenario, an acute presentation, or an elective presentation. On the ward, it's post-operative, usually, probably post a diagnosis. But so normally a GP or a doctor will see them in their rooms or in an emergency situation. Okay, ED or clinic. All right. So something that happens acutely versus chronically. Okay. So you need to know the diagnoses, and you need to know a way to remember it, and you need to know an easy way of remembering things. Now, basically, it comes down pretty easy. Okay. In orthopaedics, what are the main acute diagnoses that can occur? So if we're looking at a shoulder, someone comes into ED, they can come in, they've had an injury, they've fallen off a motorbike or push bike or something, or they've fallen playing golf, I don't know what they've done. How will they, what are the main diagnoses that can occur traumatically? Fracture. Dislocation. And what else? Sprain. So you can have fractures, dislocations, or you have ligament injuries. The shoulder, acute tears of the tendons can occur, the rotator cuff, but they're less common. Usually they're actually acute presentations of chronic conditions. But fractures and dislocations are very common. Okay. What things can look like an acute presentation, and it can be one of the orthopedic emergencies, but it's not actually a fracture or dislocation. They come in severe pain. They may remember some trauma. That's more of a chronic type thing, but they might. So we'll come back to that. So I'll give you a clue. They come in, they remember some trauma. They come in severe pain. They can't move the joint. You don't think it's a fracture dislocation. You've got an X-ray, and they've got a bit of a fever as well. Septic arthritis. Yeah. So they often remember. They always remember some traumatic episode. Everyone tries to. If one of your family members gets a cancer or something, I've had this, and everyone wants to try and put it back onto it occurred because of some exposure to something, but everyone wants to blame something, or try and justify it. But sometimes these things occur out of the blue. And I was doing a clinic in private. There actually was this new clinic I was going to, and the first patient they referred to me was someone who was uninsured for a shoulder, what they thought was a cuff tear. And really, it's really hard to treat an uninsured patient in that scenario, because what are the options? Like, you know, if they need to have surgery, it's going to cost a lot of money, and it's hard to give a proper, you can give a diagnosis, but there's not, you got your hands tied if they want to go for an operation. So I was a little bit worried about how easy it was going to be to treat this guy, but I thought it was best I see him, at least go through the options. And I saw him, and the first thing I saw him was his arm was exquisitely tender. And he actually didn't look quite, you know, most people have a good glow to him. He just looked a bit, almost sweaty, but didn't look sweaty, but he just didn't look well. And you don't know how important it is. It's that often the vibe of a patient is actually a real important thing. It's something you can't teach a computer to diagnose or anything. It's a sort of feeling you get from a patient. And he didn't look well. So anyway, I examined him, and his shoulder was exquisitely tender. And he was supposed to have had an injury where he was shutting a boot a few days earlier, and he felt this pain. And the GP had done an ultrasound showing a cuff tear, but he was older, so a lot of patients who are older do have cuff tears. He just didn't look right, so I thought, I'll just take his temperature, and his temperature was 37.8. And so he was uninsured, he had a temperature of 37.8, and I thought, this guy's got septic arthritis, a primary septic arthritis, which is exquisite. I think I've seen one in 10 years. I think he's the only one, actually. Might have seen one other one, maybe. And so I rang the Flinders, and because we were up in the Flinders area, and passed it on to the registrar, who was a little bit sceptic that it would be that. Sure enough, I sent off bloods before I did, and the results came back to him before I heard what actually happened to him. CRP was 400. So I was so lucky I saw this guy, and it was actually, you know, he ended up having a few washouts. I haven't heard since how he's got on, but I'm so pleased I saw him, because if they'd been missed for a few days, he could have been worse off. But very rare diagnosis, but I kept it in my surgical sieve as one of the 3 acute presentations, and kept it in the back of my mind. And really, it's just unusual way of presenting. But most injuries will be a fracture or dislocation. Okay. So when it comes down to, so you know the acute presentations can be fracture, dislocations, infections, and maybe a tendon tear. How else can we divide it up to help us form our diagnosis so we can remember these things? So when you're working as a GP in years to come, you're remembering, what's those shoulder things can occur that come in acutely? Oh, there's fracture, dislocations, infections. How else can I remember the things that can occur? And you then use an anatomical division. And what can be broken in a shoulder? I mean, how hard is it in the shoulder? How many bones are there in the shoulder? Well, 3 really, isn't there? 3. You got your scapula, which goes in the glenoid or the coracoid. You got your humerus, proximal humerus going to the shaft, and you got your clavicle. Okay? So you got 3 bones. Okay? So someone falls over, they could break their clavicle, they could break a glenoid less commonly, or they could break a proximal humerus. Okay? And so obviously if they come into acute presentation, they're sore in one of those areas, then the clavicle can feel the whole way along it. You know, the humerus can feel all the way down the shaft. You can feel along the body of the scapula. You can actually form the diagnosis. You know the answer before you've even done any tests at all. Okay? What can be dislocated in the shoulder? What joints are there? How many joints are there? Remember, I like to divide everything into 3s and 4s. 3, well done. So, you know, by the way, when we ask these, you're on that ward round, you must have all been there, where you go on the ward round and the guy goes on non-stop about, you know, how important it is to get have the diagnosis before you can form know the conditions are going to occur before you do a diagnosis, and he keeps repeating himself. And eventually turns to someone and says, what do you think is really important to know about forming a diagnosis? And the person says, oh, knowing what conditions can occur, sir? And everyone else goes, Christ, you said that 12 times. And the surgeon goes, yeah, really good, well done. And you think, bloody hell, he's just sucking up to him. That's because what we're doing is getting you to practice it, to repeat it 100 times. So you actually, first of all, know you've been listening, and second is it gets it's like practicing that tennis shot 200 times, so it rolls off your tongue when you say it. So it's all just becomes second nature to you. Okay, so there's three conditions, 3 joints, and what are those joints? You got your venohumeral joint, you got your AC joint, you got your sternoclavicular joint. Okay, and so if they've had an injury and they're sore in one of those spots, that's what you're thinking. Obviously, a glenohumeral joint dislocation looks pretty obvious. The shoulder looks deformed, they can't move it. AC joint, there's quite a deformity there, but they're obviously quite tender over the AC joint. Sternoclavicular is a little bit more difficult to diagnose, but just got to think about it. It's more rare as well. Okay. And then the same joints can get infected. Okay. Sternoclavicular infections are less common. It's actually more common with IV drug use. AC joints, not that common either. And glenohumeral joint glenohumeral joint injections, well, I've seen one, but they're pretty rare, but they can occur after surgery. If someone's had surgery and they get an infection, it might occur there. So there are main diagnosis and acute presentations. Okay. What are our chronic presentations? How many chronic conditions are there, do you think there are in the shoulder? 3 or 4? Yeah, it was 3 or 4. What's the most common shoulder condition chronically that might present electively to the clinics? We already had a hint a minute ago. Impingement syndrome, which basically is a rotator cuff tendinopathy. Okay, so impingement. Okay, that's where the rotator cuff muscles get impinged underneath their acromion or cause some pain from in the painful arc. Okay, how many muscles make up the rotator cuff? What a coincidence! There's 4 there. Okay, there's supraspinatus, infraspinatus, subscapularis, and teres minor. Teres minor is a bit of a hanger-on. He's that guy that sits in the corner and does nothing on your holidays and stuff. You know, you're going the night out. You know, he never says anything, never does anything, but he's there for the ride. You know, he's enjoying himself even though he doesn't do much, right? So that's the teres minor. It doesn't ever cause any problems, but he's one of the rotator cuff muscles. So the 3 other ones are really the most important ones, but there's 4 in the group. I actually like to think of a couple of others as well, a couple of extra friends. Long-headed biceps goes through the shoulder, and that can get impinged and also cause tendinopathy and cause pain. And also the other condition, which is not really a muscle, well, the deltoid is another important muscle because that's the powerhouse of the shoulder. The other part, when I think of rotator cuff, I also think of the AC joint. And the reason is when you get AC joint arthritis, you have pain at the end range of motion, while rotator cuff spectrum is pain in mid range of motion. All right. So how many different parts of rotator cuff, what are the different spectrums of rotator cuff pathology can you have? You've got bursitis. So how many different groups are there? There's bursitis, and there's how many? 4. Okay. You've got bursitis. If you get older, you get tendinopathy. If you get older, especially if you smoke, because that damages the tendon as well, you get tendon tears. And if you get tendon tears, the shoulder can start subluxing a bit, and you can get secondary arthritis, and that's called rotator cuff arthritis. So that's the bulk of my work is rotator cuff pathology. But what other conditions can occur in the shoulder? Frozen shoulder, exactly. So rotator cuff affects the tendons or the range of motion. Frozen shoulder leads to glenohumeral joint stiffness, okay? It leads to stiffness in the shoulder. And no one really knows why it occurs. It's usually about a 30 to 50-year-old age group, okay? And it occurs out of the blue. How many stages of rotator cuff, of frozen shoulder are there?
3 or 4.
Yeah, well done. So there is. It's weird. If you actually think about this, in all areas of medicine, you can divide it. It helps you remember things. Okay, so I did it subconscious. I don't know how I did it, but I did it with renal years ago. And I really enjoyed the renal medicine because actually it was all very sensible. You know, just all you had to do was take a good history, take a blood pressure, and do a urinalysis, and you had all the answers. Really, you know, ultrasound nowadays helps you a bit more, but basically it's all you could divide up into those simple tests, simple things. You had all the answers with a good urinalysis and a blood pressure. And the same thing with all areas of medicine. You divide things up into simple things to make it easier to remember. Because what's the most important thing right at the moment? What's your goal right at the moment? To be honest. Exactly, you pass the exam. So you can get the holidays and have a few beers to forget what you've remembered. Okay, and the easiest way to pass is for you actually to remember stuff, so you can actually repeat it in the exam and actually become good doctors. We want you to be good doctors, and we want you to be good safe doctors. Okay, so the best way to teach things is to teach you the safe stuff, because in medicine we're very lucky. It happens in law too. I mean, you can actually, in law they have open book exams and things, because it's not really about remembering all the stuff, it's actually knowing the technique to do it. In medicine as well, we don't have to know all the answers, okay? We can always ask the audience, like in Who Wants to Host, what is it, Millionaire, whatever it is, Who Wants to Be a Millionaire? You can ask the audience, that's called going to a grand round. You can phone a friend, that's called getting a consult. You can come back and play the next day. That says, oh, this is a very difficult problem. I think I'm going to have to sit down and discuss it in more detail with you, sir. Can you come back tomorrow? In the meantime, you quickly go to Google and any textbooks. So, and phone a friend and go to the audience. So we've got that options, okay, for the tricky things. And in medicine, they do it all the time. You know, they do a test, they come back the next day to find the results, and do another test, and come back another 6 years later, they've got all the answers. So. But in orthopaedics and stuff, we like all the answers within minutes. We're a bit impatient that way. And that's why we like orthopaedics. I say to the registrars all the time, one of the good things about orthopaedics is people can be packaged. I don't have to, most of the times I don't have to go to bed worrying that I've missed something. I can actually sleep better at night for it. So it's one of the nice things about orthopaedics. And plus also people often get better. If someone gets sick in orthopaedics, we really hate it. We don't like people getting unwell. We like people to get better. We come across as a tough guys. We're actually the softies. We hate people getting sick. So okay, so we've got frozen shoulders, but 4 stages. Okay, you got the acute painful stage, and that's really awful. You can actually see those patients come in the moment they walk in the waiting room. You know they've got frozen shoulder. They look sore. It's an awful condition, frozen shoulder. They're really in pain, and you really feel. You want to give them a hug. They look so awful. You know, and they're sore. They're not sleeping. They're teary, and the moment you got to move the shoulder, it's really sore.
So what is the cause of it?
Yeah, it goes through for some reason. The actual capsule just scars up and just contracts down, and there's some sort of inflammatory element to it. No one really knows the cause to it. One of my mentors or a senior colleague from the United States, he actually suggests it might be neurogenically. It's almost like a neurological type of condition. A lot of people disagreed with that, but I don't know. I reckon he might be onto something because it's similar to when someone gets a trapped nerve in the neck or the back. That's a pretty bad thing too. Most pain, you have a bad injury, but most people, they're sore, but it's not quite as centrally mediated. But frozen shoulder and trapped nerves they really are awful pains. So you feel for them when they get it. So no one knows the answer of why it's caused though. So it's associated with trauma. It's associated with ladies who have had breast cancer and radiotherapy get it. And it's very strongly associated with diabetes. There'll be a few other associations too, but they're the main ones. There's 3 main associations. So they go through this acute painful stage, and at that stage they're still moving their arm pretty well. Okay. And often they're doing ultrasound, they'll find a bursitis, because you ultrasound everyone's shoulder, they find a bursitis. They never not find a bursitis. So people think it's a bursitis, and try an injection, it may work, but it probably doesn't. And then they get into a stiff phase, and that's usually by the time I see them, so it's easy for me because they've got stiff as well, and I'm thinking, gee, they've got a frozen shoulder here. Okay, and you can do an MRI to help confirm the diagnosis, because that sometimes shows some capsular contracture, but really it's a clinical diagnosis. The MRIs often can miss it too. So, then the pain starts settling. That's going to stage 3. Then it remains stiff, but there's the pain settling, and then it starts thawing, and that's really the stage 4 stage. Most people remember the 3 stages. That's the ones that Apley talks about, but I like to think of it. To me, it's 4 stages really. And the thing with frozen shoulders, the longer you wait to do something for them, the better they do. So the treatment options are manipulation and injections, or capsular release, start off with simple things. You can try some physio, which people think is controversial because they think it might flare things up. But I usually tend to try some physio, and hydrotherapy is good. Pain relief, give it time. And if that doesn't work, then injections and steroid injection and manipulation, or a capsular release. But really, I very rarely do any procedures nowadays for it, because I try and wait it out. Because by the time they're actually, the people that do the best, the ones that are through that painful stage, and it's just in the stiff phase. And by that stage, people are so happy to get rid of the pain that they don't care about the stiffness anymore, and they don't want anything done. So,
How long does it take normally?
well, everyone varies. I mean, some of them can take up to 18 months. Another thing, a thing you can do to try and help speed up the process is a steroid injection just under ultrasound guidance into the shoulder itself, and that can work quite well. Or they can send the sugars all over the place if they're diabetic. So,
What percentage of them self-resolve?
oh, they always get better. Yeah, always get better. It's just a bloody awful condition for them while it's happening. Yeah, always get better. And that's, to be honest, I've tried different procedures. Where I used to have really good results from manipulation and injection, and to help speed up the process. But I have seen a complication from that, which put me off it, and so I've gone very conservative for them now. So and really, it's just a matter of just keeping, you're almost giving them counselling just to try and keep them on side while they ride it out. I would, one of my head surgeons here had bilateral, and I would talk to him. He asked me for some advice, and I told him some options, and he said, nah, he kept operating with it, and he's fine now. Most doctors themselves try and avoid surgery like the plague, so especially surgeons. So we've got frozen shoulders, we've got rotator cuff. What else can occur in the shoulder? Arthritis, yeah. So what types of arthritis are there? So there's osteo and inflammatory, okay. But there's really three main diagnoses, isn't there? Because everything's reinforced. Okay, there's primary osteo, or there's secondary osteo, or there's inflammatory. Really? So primary osteo is that person that's unfortunately comes from a family that everyone in the family's got arthritis and there's wear out quicker. That's a bit of a bugger. Some people are the opposite, they never get arthritis. They're very lucky. Then you've got secondary arthritis. And has everyone got a car or got access to a car at all? Yeah. So you probably don't have to worry about it yet, but you have to worry about changing tyres at some stage when they wear out. You probably don't realise, you just get mum and dad to do it at some stage. But the tyres will wear, okay? And what makes the tyres wear quicker? More use, yeah. So the more you used it, if the tyres aren't balanced correctly, they'll wear quicker. If you bought cheap tyres, they'll wear quicker as the rubber wears out. Okay? If you do burnouts in it, that will make it wear quicker. If you're carrying too much weight behind the car or towing a boat, it'll wear quicker. All those things cause the same things to happen. All right? If the shoulder's not balanced, or the joint's not balanced, it will wear quicker because it'll actually start moving out of whack. So when there's a rotator cuff tear subluxing slightly, it wears quicker. If they've got bad genetics, which is unfortunate, you'll wear quicker than someone with good, lucky genetics. Okay? It's not bad, it's just a different genetics. I wouldn't just call it bad, it's just different, unfortunately. If they're overusing it, like if you're playing tennis, I'm sure Andy Murray and Nadal and all them will probably get arthritis in their shoulders because of sometimes they'll whack it down. So I'm sure they wouldn't get through their career without getting arthritis later in life. Then of course, if you've had some sort of operation where you fractured your shoulder and there's been a disturbance of the joint surface, that can lead to arthritis. Or if you get burned out rheumatoid arthritis, that can lead to secondary arthritis, osteoarthritis. So inflammatory arthritis can burn out and lead to secondary osteoarthritis. So primary, secondary arthritis, or inflammatory arthritis. Luckily, arthritis is less common in shoulders, although actually having said that, in the last couple of years, I reckon I've seen more arthritic joints in my life than I had in the last 10 years as a dedicated shoulder surgeon. So I've had heaps of arthritic shoulders I've had to operate on the last few years. I don't know whether it's because I've head of the unit and because of the practice I've got at Queen Elizabeth and things, but I'm just getting a lot of them. So I've had this week we've done 2 shoulder replacements, and next week we'll do 2. So we usually do 1 a month. So it's actually getting very common. So an arthritic shoulder again affects the glenohumeral joint and can lead to stiffness. While the rotator cuff spectrum, be it the impingement or AC joint pain, is actually pain in range of motion. Okay. What other conditions can occur in the shoulder? Excellent, you guys are passing perfectly because you can't think of too many, because there aren't that many more. So everyone goes, it's really hard to do shoulders, it's really hard, we'll leave it to a specialist shoulder surgeon. And reality is it's not that hard, okay? What else can occur? Referred pain from the neck, okay? A trapped cervical disc, and that's actually quite common. Where the hint for that is that usually causes pain down the medial border of the scapula, which people think is the shoulder. So shoulder pain is more, like impingement is more down the side, or glenohumeral is more the front. Pain down the middle border of your scapula, classic of neck. It might be the shoulder, but it's pretty rarely the shoulder. It's classic of neck. And pain along here, and then if you speak to them, they say, yeah, it's coming here through my shoulder and back. That's your neck. So I see that all the time. They go, I've got arm pain. You go, that's the shoulder. You've got forearm pain. You go, that's the elbow. Okay, so it's actually weird where the pain presents. It's always down the way. Okay, it happens the same in the hip. When I used to do hips, I did bilateral knee replacement, one at a time, but bilateral knees on a guy. Bilateral hips on a guy who had bilateral knee pain. He never had hip pain. And actually exactly the same scenario. People say the hip. They say, I've got hip pain. You go, that's your back. And they go, I've got groin pain. You go, that's your hip. Okay, or you've got knee pain. They say that could be the knee, but it also could be the hip. Or the back. So you got to think out. Just know the picture they present with. Okay, and that's just what you get with experience. So you get referred pain. So it comes down to, electively, you've got the rotator cuff spectrum, you've got frozen shoulders and osteoarthritis, and you've got referred pain from the neck. 4 main conditions. You get some rarer things, like you get some avascular necrosis of the shoulder. You can get a secondary cancers in the shoulder. Okay, but usually those things you're watching out for something that doesn't quite fit. Okay, but you think with the more common things. Okay, now the only thing that's missing from this picture is the slap conditions and labral tears, and they're the ones that fit in the middle. Okay, because at the moment we've got 2 main things. We've got acute and chronic, and as I said, everything occurs in 3s and 4s. So we've got to have a third diagnosis condition, don't we? So we've got those middle ones as well. That just jump in the middle and want to do. It's like the guy that comes to both groups. He goes to the party, wants to go to the engineers pub crawl, and wants to go to the medical students pub crawl. Like, he goes to both. That's a slap tears. He presents with acute labral tear, but comes back. He's coming back to the clinic because either keeps redislocating, and that's what's caused the labral tear, or he's got pain when he puts his arm in certain positions. So in the past, probably about 5 or 10 years ago, people got on about labral tears causing pain, and they can catch in the shoulder. But I think true labral tears aren't as painful as people think. I think they aren't the worst scenario. I think a labral tear usually occurs after a dislocating episode, okay, or unless it's got some abnormal pathology that's made it rip, but usually it's after a dislocating episode, and then they usually present with recurrent dislocations, okay. But there will be people who have had a dislocating episode or a traumatic episode of throwing something and have torn the labrum, and that can present with some pain. It feels like there's something catches in their shoulder, but it's probably more minor subluxations that are occurring. Either way, it's a diagnosis of probably exclusion. They've got pain, it's not quite right, and you need to investigate them as a suggestion of a labral tear, in which case you treat it. Okay. Most of the ones you'll see are like people who come in. A 20-year-old guy fell while playing footy. He's dislocated his shoulder, and ever since then it doesn't feel quite right. Occasionally he'll pop out a joint, and he's had to go back into hospital. That's how most labral tears will present. So there are conditions in our shoulder. It's not that hard. If you know there's only about 8, 9 conditions all up, really, how hard is it? It's even easier for hips. I better be careful because I'm recording this and I'll play it back. But the hip surgeons, I mean, what conditions can occur in a hip? All right, we're not doing hips today, but what conditions can occur? How do you divide them up? What's that? Perfect. Okay, acute and chronic. What acute conditions can present in a hip?
Fracture.
Yeah.
Dislocation.
And well, the tears aren't that common. Yeah. Infection, fracture, dislocation, infection. What chronic things are electively going to present with a hip? Arthritis. What else? Referred pain from the back, maybe, and that's it. How hard is it? I mean, you can get trochanteric bursitis, you can get ischial bursitis and things. You get some tendinopathies, they say, but usually, I mean, I think a lot of these tendinopathies are people who are actually getting older and want to call it tendinopathy, but really they're getting early arthritis. They ran out of things to treat. There's all these hip surgeons running around, they've got nothing to treat, so they actually had to go and make up a new diagnosis called femoral acetabular impingement, which is probably, it's a definite condition. They're just copying the shoulder surgeons, with the idea of impingement, But it's a definite condition. It probably impinges this cam effect, which leads to secondary arthritis. But there's been a big push to do label, arthroscopies and label debridements. But I think they will find, similar to us with our label experience in shoulders, that it's probably not the main issue. I think it's probably a cause of arthritis, and there will be label tears that cause problems, but it's probably not every person's got a label tear and needs an operation on it. And I think it's really just a secondary cause of osteoarthritis in the hip. So it really comes down to arthritis, or a bursitis, or repaired pain from the back. 3 conditions. Okay, so when so it's all a game, really, isn't it? In any area of medicine, because unfortunately, it's all straightforward. It's easier than everyone thinks. Let's put an example. You're doing your 5th year exam next year, right? You're standing outside the OSCE, well, you're doing your 1 year OSCE station, okay, in a few weeks' time. You're standing outside the door, you're reading the thing. There's a little old lady presents with 6 months of pain, felt down her leg, difficulty with walking. She has an antalgic ache. You please take a history and examine her. You walk in, you see her, and you see she's not crying in pain because she hasn't fallen yesterday. So you say, hello, hi, you've got osteoarthritis of the hip. You probably need a hip replacement if you can't get by. See you later. And you walk out. And the guy goes, yeah, it's perfect. And if they have to justify it, so why don't you just walk in and only spend 30 seconds with him? He said, well, it's a little old lady, she had long-standing hip pain. I saw at the end of the bed the leg was internally rotated. What other conditions occur in the hip? It has to be osteoarthritis. It's unlikely to be referred pain from the back. There's unlikely to be bursitis, it's arthritis of the hip, there's no other conditions occur, and the person goes, yeah, fine. But really what you do is you stand out, you take a full history, you take an examination, you look at the shoe wear, you look at their stick they're using, you make sure the examination confirms your diagnosis, and you talk about treatment options. But really you knew the answer before you walked in. What the trick is not to be fixated on that answer and to keep an open mind. And you'll see that every day in the clinic. You know, we've got all these patients coming through the clinic, and it's really hard for me to see every one of them. So I delegate to the registrars to see them all. And they'll come and present patients to me, and I'll take into account the experience of the registrar, and so how much I trust their examination. And I'll listen to the story, and I'll have a look at the GP referral letter, and I'll hear it, and I'll go, that's going to be that condition. If it's someone who's pretty straightforward, I'll say, yeah, that's fine, Basil, you just go and book that patient for theatre or talk about what options you want to do. If it's someone who I don't know, I might go and double check their examination or take the history myself, okay? But often I'll just pop my head in and just have a look at the patient to see what they look like, to see, you know, if they look like they're, from the end of the bed, they're very unwell, then I'll be a bit worried that they're not going to get through an operation safely. Then I want to see them myself and make sure they really need surgery and things as well. So you know the answer before you walk through the door, because what's the most important diagnostic tool you have in your whole life? If you could only have one thing you could do as a doctor, what would you want to do? History. Yeah. Your history, using your ears to take your history, is the most important thing you can do, because your history is what helps you form the diagnosis. The examination helps you confirm the diagnosis, and the investigations help you stage the condition, determine treatment options, and determine prognosis. And you could use that sentence or paragraph in any area of medicine, because that's what it's all about. And when you're speaking, doing OSCE exams, if there is a doctor there with you, it's not being videotaped or something, and you've got a chance to interact, you come up with these important sentences or paragraphs, people know straight away, look, this guy knows what he's talking about, or the lady knows what he's talking about, you know, everything's fine, you know? So, you know, so it's actually, these are the important little tidbits you throw in, and people know, look, they're on the ball, you know? If your first thing you say is, like, I don't really want to take a history, I just want to do 100 different investigations, you say, oh, gee. You know, so the history is really important. I want to get a bit of a quick history. I'm not going to go off on a tangent. I want to do an examination and get to the bottom line of it, and then I'm going to do the important investigations first. You go, look, they're on the money. Okay? So when it comes down to, so I've spent all this time, we haven't done a shoulder examination yet, because the most important part is the history, knowing what you're looking for and knowing how the history presents. So how does it all come into practice? Well, it's easy. They come in a traumatic scenario, they've fallen, had an injury, car accident or something, and they've got pain in their shoulder. First of all, you have to obviously always remember the doctor's ABC, of course, initially, you know, depending on the presentation. But when it comes to the specific diagnosis, then you need to find out where they're sore. And you use the standard technique of orthopaedic examination, which includes look, feel, move, and X-ray. How many areas of that is there? 4. Okay, so it always comes back to the same thing. You can divide things up. You know, of course, you might think I'm forcing the issue to get 3 or 4. Ironically, it's actually the other way around. This is why I've worked it out, and it happens to fall on 3 and 4 all the time. I'm sure there'll be other areas that don't, but you could probably divide up into 3 or 4. But for some reason, it always seems to fall into 3 or 4 things. So, you know, so it actually helps me remember things easily. Okay, so you'll probably worked out different ways of remembering, but I've got a very visual memory. Just seeing the little patterns of things going off helps me remember it. So you see them, and they come in, and you're going to take a history, and they're falling off a bike, they're sore in their shoulder, and you say, where's it sore? And of course, when you're taking a history for an orthopaedic or surgical exam, always remember you're taking it as if you're a doctor about to see the patient in a casualty, and so always start thinking like a doctor in that scenario. And what's the first thing you do if someone comes in with a traumatic surgical type presentation? If they say, apart from taking a history examination, you've got to think right from the start. If I was a doctor in casualty, what would be the first thing I'd do to this patient? I'd start fasting him, and I'd be making sure that down the track I'm going to send off bloods ready for the theatre to see if they're fit. So you're thinking like a doctor, and when you're taking a history, you're thinking like a doctor too. So you're going to be saying, what drugs are you on? Are you on any blood thinners? You're going to be saying, when did you last eat or drink? But also you're going to be taking a specific history regarding that condition. So doctor's ABC, and remembering you're going to be like an intern in casualty or an RMO in casualty and be like a surgeon. But the important parts of the history is, where are you sore? Okay, saw along the clavicle, you saw in the subacromial space, you saw down the humerus. Okay, and try and localise it. And if you actually think about the clavicle, and our friend here, bring him over here. Oh, he doesn't want to come. The skeleton over there. Stuff. I don't want to break the thing. So, if you think along the clavicle and have a look at it, the clavicle is very easy to feel. The proximal humerus are very easy to feel. You can actually see and feel all those areas. So where are they sore? They sore along the clavicle, the proximal humerus, in the supraspinalis fossa, which area? Then you feel along those areas, okay? You can feel along the whole edge from the sternoclavicular joint, you feel your own one along the clavicle. You get a little bump, just before you get laterally, you can feel an AC joint. The older you get, the easier it is to feel. And then you go a little bit more laterally, you feel the edge of the acromion. And if you put your arm in this sort of position, and then put your hand just in the front of your shoulder, and you turn your extend and rotate your arm, you can actually feel the bicipital groove. And the proximal humerus, you can feel a little groove, and the long-headed biceps, that's underneath that. Okay? You can feel down the actual proximal humerus laterally to that, that's the supraspinalis insertion. And the supraspinalis muscle belly up here. And you look at it, feel all those areas. Okay? So you can actually feel the anatomy pretty easily. Then you actually do some movement. And of course, if they've had a fracture or dislocation, at the moment you go to move them, they're going to be sore, and you might feel some crepitus, but you'll stop there and not do anything more. And then you do the most important thing of the lot, which hardly ever get referred. What's the most important investigation for orthopaedics? What do you think? X-ray. Yeah, look, feel, move, and X-ray. It's even on part of the whole mnemonic. No one ever remembers to bring it. A number of times people say, oh, he'll just do an MRI. Oh, I might do an MRI, but often the X-ray will give me the answers that will give it. So an X-ray is really useful. It's like that urinalysis on the renal. It's like the ECG on a cardiology. Cardiology was also a really good area because you needed a history and ECG, and you knew all the answers. It's great. So a lot of them. Gynecology, you need a beta HCG, and you need to have all the answers there. So that and a few hormone levels and stuff. So yeah, gynecology is a little bit tricky because there's some nasty things that can go on deep inside, which are harder to pick up. But it's still we can divide up into those little areas. Okay. So neurology is a little bit harder, I think. But there's some good examinations on neurology. So we do our look, feel, move, and X-ray, and we've got most of the answers. They're sore at the clavicle. They've got a big defect there. The X-ray shows a clavicle fracture. They're sore at the AC joint. With their arm sitting down, you can see a bump there. X-ray shows an AC joint dislocation. Okay, you can grade it, how bad it is, whether it needs surgery or not, but it's an AC joint. They're sore, and you go to move their arm, and they scream, and there's a little crepitus. Proximal humeral fracture. It looks deformed, so they don't want to move it at all. Glenohumeral humeral joint dislocation. Piece of cake. You do all that, they're sore as anything, and X-rays are fine. You're thinking, what about the temperature? The low-grade temperature of 37.5. Oh, that's the second one I've heard about. I only heard of one other one before. That guy saw one back in his clinic 2 years ago. So he's got septic arthritis. Okay.
When you do your inspection, you look for examination. What are the key things?
Okay, so we're looking for deformity. Okay. So is there any deformity of the clavicle or the shape of the humerus or the shoulder joint? Is there any wasting of the deltoid or supraspinalis when you turn them around, supraspinalis fossa or infraspinalis fossa? Okay. You're looking for any scars. Okay. Anyone think of any other ones you might have read about? I'm trying to think. On my feet here. Erythema is good. The thing is, people worry about septic arthritis looking for erythema, but usually septic arthritis is deep down, so you hardly ever see erythema. If you've had a bad bursitis in an elbow or a knee, you'd get prepatellar bursitis, so you'd get erythema there. But around the shoulder, even then, it still wouldn't get much erythema. But certainly around the scar, if they had a surgical scar, and it's all red around that, or it's discharging pus, that's important. So, okay.
Are there any special tests of the shoulder?
Yeah, we'll come to that in a sec. So special tests, we're going to look, we're going to feel. Do you want to know what we're looking for feeling? That's pretty obvious, isn't it? And moving. Okay, so we come to the so clinically, we'll just go previously on the chronic scenario. If they're coming through, it's the same scenario. You're just looking where they're looking for deformity, looking for wasting more, looking for scars, and you're feeling the same area where they're more sore. And moving is the most important part, even more important than the special tests. Okay, because that gives you all the answers nearly. All the answers nearly doesn't make sense. Most of the answers. Okay, so you ask, what types of movements, motion is there? passive, perfect, active and passive. So you guys know all this stuff already, which reminds me, by the way, when you are working in in your intern and casualty or something, and you see someone with a septic arthritis or something you think it is, trust yourself, back yourself, and definitely fast them. Because the number of times I used to see, it probably doesn't happen anymore, but when I was a junior doctor going to see them in casualty, they go, yeah, the less the junior doctor would be, or more junior doctor would say, look, the patient, I thought he might have septic arthritis, but I wasn't sure, so I fed him anyway. You go, no, you're spot on, you got the answer, but now you've fed him, and now we've got to do it at 3 in the morning, you know. So back yourself, because to be honest, it's, as I said, it's not that hard. You know the stuff. It's just that you don't have enough confidence yet. So back yourself, because you will be fine. Okay, that's the important thing. Okay, if you're good enough to remember this stuff, you'll do fine in it. All right. So yeah. So where were you? I've got distracted now. Yeah, moving. So active and passive. Exactly right. So motion. The motions, you've got 6 range of motions called flexion, extension, abduction, adduction, internal, external rotation. And you can do that by the side or by the side, abducted. But really, the most important ones are flexion. Okay, so we go for flexion. Extension is not. When I'm testing, I'm doing flexion, abduction, and external rotation. Are really the most important ones. If they go to lift their arm up, and they hoik their shoulder up, and they basically hitch their shoulder, okay, then you're thinking something's happening, the glenohumeral joint's not moving freely, okay, and if external rotation, they can't external rotate, you're thinking, oh, there's something's happening now. Now, 3 things can happen. If they go to lift their arm up, actively, they're not moving, okay, then it's either they're stiff, or that something's not driving it. And if something's not if they're stiff, let's start with stiffness. So they go to move their arm up, and they don't move. I can't borrow one of you kind of get up here for a second. I'll take that many notes. You're one of those ones that got a good auditory memory. I've got more visual. Come across here. You happy to stand in front of here for a sec?
Yeah, sure.
You sure?
Yeah.
Okay. All right. Okay. So if I lift your arm up here for a sec, if you go to lift your arm up and you hoik up there, okay, and you hoik it up like that, so you'll hitch it. Then what I do, and I just automatically do it now because I don't so often. What I do, I put my hand on your ankle with the scapula. Just turn to your side. So I put my the back here, so I come around this way. There's the angle of the scapula. I put my hand on that. Okay, come around this way. Now, if you go to lift it, if he goes to lift it, he can't do it, and I go to do it for him. So he's gone up there, he can't lift it, and I go to lift it, and it won't go any further. Then what's happening is the glenohumeral joint's not moving, and the whole scapula is trying to move. So if I went aside, took you aside, and actually fused your shoulder joint, the range of motion you would have would be this, because your scapula moves forward. Yep. Okay. The same way happens in the hip. If you have an ankylosed hip, you can still, and especially in a kid, they can move the hip perfectly because the whole pelvis moves, which is why Thomas's test is so important of stabilising the pelvis, which is probably, if any test you're going to do, that's the most important one for the hip. It's the most simple one, everyone forgets it because they think it's the basic one. It's the first one you learn, it's not going to be that important, but the Thomas's test is really important. Same thing here. So if you've got a fused shoulder, you can still move it arm well. So if you've got to move actively and passively, it's the same, the shoulder joint is stiff. Okay? A great way of testing with the shoulder joint stiff is to turn external rotation. If you're going to move past, you can't move past there. Because, and actively and passively won't go. Because the scapula won't be able to roll in past the rib cage. Okay? So ER tells you straight away there's no glenohumeral movement. If there's no glenohumeral movement, what is the causes of stiffness in the glenohumeral joint? What are the 4 clinical things there? So of the 4, which one causes glenohumeral joint stiffness? Frozen shoulder and osteoarthritis. Okay? And if they get stiff in their shoulder, I put my hand on it. Once I know it's stiff, I then do it again with the hand on top. I feel for crepitus. If there's really bony crepitus when I go to do it, what's likely happening? Osteoarthritis. But also, I know by his age that is unlikely to be the case. If it's 70, so if I see a 70-year-old, they say the GP sent him along with a frozen shoulder, I immediately think they've got an osteoarthritic shoulder, right? No, because you hardly ever see frozen shoulders in that age group, but you do see a lot of osteoarthritis in that age group. So if there's crepitus there, knows by his age, I'm thinking, oh, frozen shoulder or osteoarthritis. Feeling for crepitus for osteoarthritis. What's the easiest way of telling between the two between osteoarthritis and glenohumeral joint? Sorry, glenohumeral joint osteoarthritis and frozen shoulder. What's the difference? Easiest way? Look, feel, move, an X-ray. What's the easiest way?
X-ray.
X-ray. So you do an X-ray. I know the answer straight away. He's got no active and no passive motion of his glenohumeral joint. It's all scapulothoracic. X-ray shows osteoarthritis. I know it's osteoarthritis. X-ray shows no arthritis. I'm thinking frozen shoulder. piece of cake. Don't need any other tests. Could do an MRI to help us, to help stage the things, but really X-ray's all you need. All right. GP's forgotten to do an X-ray because he thinks I'll just do an MRI anyway, or it comes along with 5 ultrasounds but no X-ray. So the X-ray is the most important thing. All right. He goes to lift his arm up and he's hitching, but I go and move it, and passively I can move the arm up all the way. Okay, it might be a bit sore, but I can do it. What I'll do at that stage, I put my hand on the shoulder, feeling for crepitus as well. If it's a very fine crepitus, it might fit with more bursitis or tendinopathy, right? But he's got full passive range of motion, but no active range of motion. Okay. I can then. Why would that occur? So there's muscle tears. Something's not driving. So if the car is not moving, it might be the engine's not working. Okay, or the engine could be running but it's not going to the drive shaft, or the engine might not be running at all because the electrics could be gone too. What electrics could be affecting the shoulder? Nerve. So he could have a radiculopathy, like a C6 or C5 radiculopathy. So if he's got full passive motion but no active motion, it could be a nerve root entrapment in the neck, or it could be a bad cuff tear. Okay. Now, obviously, you got a test for that in a minute. I'll show the neck one is pretty easy. If we want to see what muscles are working, we can then do muscle power at that stage. Okay, and testing muscle power, we can do ER. Just put your arms in, push out against me. What muscles is that testing? External rotation. No, teres minor doesn't do anything. Remember, he's just there for the ride. Infraspinatus. Yeah, just remember teres minor is a bit of a wally. Okay, we can do this muscle power and push up to the ceiling. What muscle is that? Supraspinatus. Okay, or we can do belly press. Pull on your tummy, just with one hand, otherwise you're cheating with the other. Pull in with one. Or you can do lift off, where you put it behind your bottom and push away there. So just behind you where you put your wallet, just push away there. Okay, and that's testing subscapularis. Okay, if you're thinking neck, then what you do at the end, and it's always worth doing this either the beginning or the end, is check neck motion. Okay, and you do check inflection, extension. Often I'll say, oh, it's a bit tight there, you know. But really, the most important one is Sperling's test. And what I'll do is actually, I'll try and, you haven't got a sore neck or anything at all, no. So I don't want to hurt you at all. So you put lateral flexion, rotation, and extension. And if you put your head in that position, you relax now. But if I hold it there, they often say, oh, it's shooting down my arm. And it's a really sensitive test. It's actually my favourite test because it's actually really specific. It's actually really good. It's really.
Is it called
Sperling's, or I often write it as a neuroforaminal compression. But it's the true name is Sperling's test. Spurlings. Okay. So then we've got the middle group. Okay, so we've got the ones where they're actively and passively are stiff. You've got the ones where actively they're not moving, passively they're moving well. And you've got the middle group where they don't want to move it, but actively and passively they can do it. Okay, because there's 3 different types of different options for muscle movement. All right, just thought of that one. And so we've got, if he lifts his arm up but it's painful, okay, then we're thinking it was impingement. But if it's painful halfway up, we're thinking a painful arc, that's impingement for the rotator cuff. If it's pain in range of motion, we're thinking more AC joint. And that's when we come down at that stage to the more special tests. Okay, well, some of the special tests are the muscle power groups, but also if we come up and he's got a painful arc, well then we can test for Hawkins impingement sign, which is when you bring your arm up this way and roll it in. If that grabs him, that's impingement in that area. You do Neer's impingement sign, which is basically the painful arc. Okay, and they're called signs. The true test is actually when you put local anaesthetic in the subacromial space and see if the pain goes away, which is actually a great test, but you won't be doing that in your exams. But so Hawkins and Neer's impingement signs. The painful arc, Neer's, Hawkins is the stop position, rolling it in. Okay. If it's, however, it's pain in range of motion, if you put your arm across your chest, and actually it's really hard to get people to do this because everyone always wants to do this thing. Put your arm across, you say, put your arm across your chest and hold it there and push up to the ceiling. If that's sore, that's more consistent with AC joint. It can be similar to O'Brien's test and some of the impingement signs as well, but it's really cross-arm adduction and extension, or elevation, sorry, and that's quite classic for AC joint as well. You'll hear about pull-apart test or scarfs test quite good, where you do that, but usually I reckon that test is the best of all. You
So
can do
arm
it.
across the chest and push up to the ceiling.
Yeah.
What's that called?
One of the guys in Melbourne described it. I don't know if it's got a name. I call it cross-armoured deduction test, but yeah. So
And then can you describe Near's test one more time?
Near's test is Near's sign. It's basically just a painful arc.
Okay.
Yeah, if you've got a painful arc, that's Near's sign. You're basically keeping the arm in the pronated position, and you're going up in elevation, which is in the angle of the scapula. So it's not forward flexion. It's not purely abduction. It's halfway between the two. And it's between 70 to 120 degrees. Is Near's sign. Hawkins sign is up in the stopman position and rolling it in. Other special tests, you have a seat down, you've done well, thank you very much. And the other special tests are really for, well, we've done, really are these instability tests. We've done, I'm trying to think of any other ones I need to do before that. So we've done our range of motion, actively and passively, we've done our impingement signs, we've done our muscle strengthening. Anyone think of anything they've read about to remind me before I go on to the instability? So then it comes down to instability. Now again, the most important part of instability is the history, okay? You know, it's popped out of joint 6 times, you know it's an instability issue, okay? But I reckon the most important part of the instability test, or investigations, is actually looking at the whole patient. I mean, that's my philosophy is actually you've got to treat the whole patient in the first place, all right? So it's really important to take everything into consideration. And really, probably the most important bit of information I can gather for when someone's got instability from a history is whether their family have had instability episodes, all right? For instance, like I tore my cartilage when I was 15 by just standing up from twisting after cleaning up the Weber barbecue, and the whole cartilage ripped. And I've always been a bit hyper lax. So there's no surprise that my daughter should rupture her cruciate in year 12 by just landing awkwardly, and my other daughter keeps rolling her ankle. So I've got ligament laxity in my issues. If we'd all played footy, we'd probably all dislocate our shoulders. Lucky I played hockey and others don't play footy. So, but we probably, if we were recruiting for a footy team, and you heard that history, you go, oh, if you really took it into proper context, you'd say, don't recruit those guys. Go for someone who's a bit stiffer. Okay. But people don't do that because the footy teams, they favour their friends and stuff like that, and they've got their own little personal sort of philosophies. But if it really were really tough, and it's hard to cut people, you know, who are nice people, but if you're really tough, you'd choose people who hadn't had episodes of instability because you know they're going to dislocate other joints they're going to be off for the season. So it really is, the history is really important, okay? The family history is vitally important. Next thing is when you go to examine them, before I do any of well, I'll probably do it at the end usually, but at some stage in the examination for instability, I'll test for ligament laxity in general. Can they bring their thumb back onto their forearm? You know, I could get mine, for someone who's 51, I can almost get my thumb around there. So you've got often ladies have a bit more ligament laxity, just because their hormones in their system, they're smaller bones and things. And it is going to be a bit of a worry. It's good for me for work down the track, but the Women's Football League, which I think is fantastic, I think it's great. I actually quite enjoy watching it, but I think unfortunately there's going to be a fair few shoulder dislocations down the track from it, and cruciate ruptures, I think, because of that, because the game's sort of designed for it, unfortunately. But it's good to watch, and not dislocations. I hate watching those. Makes me feel sick. My daughter did pedal pre, and every time they rolled the car, everyone was cheering. I'm feeling sick, thinking, oh, I hope everyone's all right, you know. So I don't take those sort of things very well. I feel for the patient too much. But yeah, so the women will have ligament laxity, thumb extension, finger hyperextension. Okay, can they get their fingers back parallel with their forearm? Can they hyperextend their elbow? Can they hyperextend their knees? Yeah, there, so you've got some ligament laxity there. So, and can you put your palms to the ground without bending your knees? Yeah, exactly, just like that. I'm not very good at that. So. And there'll be a spectrum. There's a whole spectrum of different conditions. So some people will be extra stiff. And when we did some screening for one of the footy clubs, I thought the stiff people end up getting more back pain and osteitis pubis, and some people were more lax, and they nearly always had a history of a cruciate or a shoulder injury, and they could get some back pain as well. But there's more of an issue. And certainly for those people who are lax, I discourage them when they're doing the warm-ups, doing the stretches. They actually, if anything, want to do more toning exercises and more Pilates. And people who are stiff, really important to do the stretching exercises. They're the ones that do it. Unfortunately, in gymnastics, the people who are really lax, who shouldn't be doing gymnastics, they're really good at it, so they do gymnastics. And so, unfortunately, people follow what they're good at, which is a genetic laxity, which actually drives them down that path of dislocations and things. This life. So they're the general for ligament laxity. Then when we come to shoulders, it really comes down to a few different things to do. Okay, you want to test, the most important test for instability in the shoulder is apprehension sign. Okay, and I know the Royal they tend to teach it when they're standing up. I think Michael Sanders was quite keen on that idea, and I think it's a reasonable way of going. It's really getting the arm into the abducted, extended, rotated and extended position, and if they feel a bit insecure. So if, can I borrow you for 2 seconds longer again? So if they bring your arm up this way and go like that, and they go, oh, that feels a bit worrying, that's the apprehension test. I prefer to do it with them lying flat, just because they're more relaxed. And in relocation test, when they're lying flat, you actually put your hand on the side, push it backwards, and put them in that same position. And if they feel a bit more secure that way, that's called the relocation test. For looking for posterior instability, you can do it lying flat or up. You basically put your hand on the shoulder, push it backwards as you bring your arm across the chest. And you're trying to sublux the humeral head backwards. And actually one of the most important ones, yeah, okay, to sit up here for a second, is inferior instability, or sulcus sign. If you rest your arms on your lap there, and just pull down on your shoulders, you can sometimes see a little divot appear there. Everyone will have a little bit of a divot, but if they're really lax, you'll see a big divot appear. That's for inferior instability. Okay, thank you very much. Again. So they're the special tests that I use. So really when it comes down to examining a shoulder, or on investigating a shoulder, I take a good history. They take into account their age of the patient, what they're complaining of, is it pain, is it a range of motion, is it instability type symptoms, what story they've had in the past. I'll then investigate them by, first of all, if I go to examine them, I might just check the neck out first of all, okay, range of motion, do Sperling's test. I'll then look at their shoulder, look for any wasting, any scars, any abnormal deformities, or osteophytic spurs at the AC joint can be quite prominent. I'll then fill along those areas, and then I'll do motion actively and passively, and I'll do my special tests of muscle power and instability signs if I'm worried about instability.
In inspection, would you ever get them to push the head forward?
Oh yeah, okay. So be careful. In the teaching, they make a big thing about this wing scapula. I don't hardly even do that. But in your course, everyone's been taught to check for wing scapula, so you could do that as well. I don't know when that's a big issue, but it's yeah, you can get them to press off. Every group I've had to come to this year seems to be focused on that winging of the scapula. I hardly even do it, but it's but yes, you could do that right at the start. You could look for winging of the scapula, and when you're doing, you could do that at the beginning if you want to, or you work out when you want to do it. I would probably do it when I was doing motion. I'd do look, feel, move, and as I'm doing moving and heading towards muscle power, so just while you're there, push your arms against the wall and see it, do a wall press off test and see if the scapular wings. Yeah, that's it's maybe more of an issue for the paediatric age group. Yeah, and looking at the shape of the shoulder, you can get some other congenital deformities like Springle's shoulder, where the the scapula doesn't drop down or doesn't form correctly. But for adult medicine, the common scenario is not that common. So that's really the upper limb. But I would tend to use that technique for any area in medicine, okay, and particularly in orthopaedics. Divide it up into acute or chronic presentations, what their symptoms are, and then divide up the examination to simple aliquots of little bits of information. Now, I know the level of expertise you've been reading up at the moment. You've been reading Aples, you've been reading all these other books, you're doing problem-based learning. You're probably well past all this, but it's actually worth knowing the simple stuff, because if you don't know the simple stuff, it's hard. When it comes to doing exam technique, and I tell this to the registrars going to the fellowship exam, is it's important to answer the question. The cleverer and smarter you are, the more you think past the question, all right? So you think, what's he asking me? He's going to go that part, The more you know, the more you're thinking past it. But you can actually lose sight of the actual answer and get muddled up in where you're going rather than actually just answering the question. A simple example is, and this is just ridiculous how stupid it was, my fellowship examination, I've read last 5 times, I knew it back to front, I was doing my anatomy part of it, really important. The first part, we had an anatomical specimen on the table. They asked me to have a look at the spine, all right? And it's a pretty high-tech, full-on exam, and I'm pretty nervous. It's a final exam after all these years of study. They come up and go, well, what's this here? And they point to the spinal canal. And I thought, he's looking at the L5 nerve root. And I was ready to ramble off the L5 nerve root and all the information about it. He goes, what's this? That's the L5 nerve root. He said, no, this big thing down the middle here. And I went, that's the spinal cord. He went, very good. All right, next question. And I was sitting there going, hey, right, okay. Am I doing that bad? That's got to ask me the simple stuff. He comes to the next one and I said, what's this muscle here? And I said, what's this here? And he points to the gluteus maximus. And underneath that's the sciatic nerve, of course. And I thought, he's going to the sciatic nerve and going to go through all that. So I went, oh, that's the sciatic nerve. There was no, the big thing over the top. And I said, that's the gluteus maximus. And I was about to start origin insertions. He goes, no, very good. Okay, next one. Right. And it was just, you know, getting me settled in. Right. But really, you know, imagine if I'd stuffed all that up. When, you know, that's when they actually can throw a few curveballs at you. So really they're asking you the simple stuff first. Right. They're asking you simple. You answer the question and you go to the next step. It's the same in medicine. Okay. If you have a look on my website, I try to write up information about pretty straightforward stuff until the basic stuff, because it gets too confusing. I don't know if any of you have been water skiing. When I went water skiing once, I took forever to get out of standing up on the bloody water skis, because people were telling you not to pull your arm in, make sure you stay out of the wake, all this sort of stuff. What they forget to tell you is the basics about bringing your feet underneath your body and stand up. Once I worked that out, you know, if you take the basic stuff, then you can focus on all the other stuff afterwards. All right, you build on it. You need a foundation to build on, and that's what I'd recommend for you. Okay, because in the end, if you've got that foundation to work on, if you can pick up, you know, if you remember half this stuff, you're doing, or a quarter of this stuff, you're doing really, really well. Because orthopaedics in the end is probably about 20% of what you'll come across. Because in the end, what's you know, everyone you know, it's quite nice being in medicine. You get lots of fun with it all and everything. It's a good community. You know, got good job prospects and things like that. But in the end, what really drives you, no matter what you think it really drives you, most of us are driven by the fact you actually like helping people. And there's nothing like more fun than when people come up and ask you stuff and you want to give them advice. Or if someone is sick, you know, or crook, you want to go and help them and stuff, they actually get a buzz from it. That's the best reward you can get. I really enjoy that. And if down the track, you might be a cardiologist. But if you can actually remember some of this stuff, and your friend falls over and injures the shoulder and it's aching away, you say, yeah, that could be a bursitis. I think we should give you some physio for it. And go from there and try some injections and things. That helps you a lot. Okay. So I haven't gone through all the treatment options. That's what for you to look up. And I'm welcome for you to ask me a few questions now about that. Okay. But I'll help you with the diagnosis. Okay. So any questions at all?